Hello, my name is Kim Lindblade. This unit reviews the principles and strategies of preventing the reestablishment of transmission after elimination has been achieved. By the end of this session, you should be able to explain the concepts of receptivity, rate or risk of importation, malariogenic potential, and reestablishment of malaria transmission. Explain the 3 different methods to estimate receptivity. Describe the 4 different methods to estimate rate or risk of importation. Explain how to maintain vigilance for malaria after elimination, and describe the ABCDEs of traveler health programs. Our focus in this training has been on elimination of malaria, as that is the important goal that countries are working towards. But what happens after elimination? Is it all just champagne and fireworks after transmission has been interrupted? No, it's not. While elimination and certification are critical achievements, they're not the end of the malaria story for a country. As we said in Unit 1, continued prevention of reestablishment is required until malaria is eradicated from the globe. In this unit, we will discuss the principles and strategies for countries or areas to prevent reestablishment after elimination. Let us start this discussion on prevention of reestablishment by clarifying again the difference between imported, introduced, and indigenous cases, and define reestablishment. This image shows a small village after it has eliminated malaria. After a country or area has eliminated malaria, imported cases may occur if people move into the area from malaria endemic locations or return from trips to malaria endemic areas. Near international borders, it is also possible that a shared mosquito population will bring malaria across the border. A resident of this village returns after travel abroad and is infected with malaria that he acquired during his travels. This is the imported case. If the area has mosquito vectors, the imported case could transmit the parasite to another person through the mosquito vector. This second case is called an introduced case, or F1, or first-generation case. On more rare occasions, transmission from an imported case to an introduced case can also occur through blood transfusion or other hospital-associated procedures. If measures are not taken rapidly to reduce the chances of onward transmission, the introduced case could transmit the parasite to another person through the mosquito vector. This third case is classified as indigenous, or F2, or second-generation case. Finally, if this chain of transmission is not stopped, it could continue, in which case we would consider transmission to be reestablished. The WHO minimum criteria for reestablishment of transmission is the occurrence of at least 3 indigenous cases of malaria of the same species in the same focus for 3 or more consecutive years. You can see from these criteria that reestablishment can occur at any time after malaria transmission has been eliminated. However, there is a formality to this definition once countries have been certified malaria-free, because reestablishment of transmission after certification can cause countries to lose their certification. Reestablishment of transmission results in sustained indigenous malaria transmission. In other words, if only an introduced case or cases occur and do not result in further transmission, then transmission is not reestablished. Let us clarify a couple of terms because sometimes people get confused between reintroduction and reestablishment. They are related, but they mean different things. Reintroduction of malaria is the occurrence of introduced cases after malaria elimination. Introduced cases signify local transmission, and this is concerning as it is the first step towards reestablishment. However, it is common for countries that have eliminated malaria to have a few introduced cases because it can be challenging to identify imported cases early enough to prevent all onward transmission, although it is important to try to prevent introduced cases from occurring. Nevertheless, the occurrence of introduced cases should be an alarm bell to the program, as this indicates the presence of local vectors and local transmission that could go on to become reestablished. Measures must be taken immediately to interrupt transmission again. Reestablishment of malaria after elimination is much less common. Reestablishment of transmission means that local malaria transmission is ongoing. Reestablishment is suggested by the occurrence of 3 or more indigenous malaria cases of the same species per year in the same focus for 3 consecutive years. From these concepts, we can see that preventing reintroduction of malaria will be more difficult than preventing reestablishment of transmission. But our goal is to prevent reestablishment of transmission. As a result, countries have a period of time after finding introduced cases to quickly intervene to interrupt transmission before it becomes reestablished. There is a range of conditions that make it more or less likely that reestablishment could occur in a given area. The most important condition is the presence of efficient malaria vectors. Without malaria vectors, transmission will not be reestablished, so there's no risk of reestablishment in parts of the country where vectors do not exist. Second, the climate must be suitable. If the temperature is too low for the parasite to develop within the mosquito vector, as could be the case in some high altitude areas, then transmission cannot be reestablished. There must also be contact between humans and mosquitoes. If there is good vector control and house construction that prevents mosquitoes from entering dwellings, the risk of reestablishment will be much lower. After elimination, the only way for parasites to be reintroduced into the area is through importation, whether in a human or a vector. The risk or rate of importation will be an important factor to consider when estimating the risk of reestablishment. Although not relevant everywhere, in some areas there may be parasites from other regions that are blocked from being transmitted because they're not compatible with the local vectors. For example, there is a suggestion that Plasmodium falciparum cannot be transmitted by Anopheles sinensis in China. And finally, the risk of reestablishment will be much higher in areas where the surveillance system is not adequate. If the health system is inefficient or difficult to access, it might take much longer for an infection to be identified and treated, potentially leading to onward transmission. Additionally, if efforts are not made to ensure that healthcare providers are actively looking out for potential malaria cases, that is, if healthcare workers are not sufficiently vigilant for malaria, then surveillance will be inadequate and transmission may be reestablished. Once a country has reached elimination, there are 5 key strategies it needs to implement in order to prevent reestablishment. Some of these strategies are similar to those deployed for elimination, but they may become more important during the prevention or reestablishment phase. There is also some overlap between several of these strategies. For example, improving the early detection of cases can also reduce the malariogenic potential, as can reducing the risk of importation through addressing travelers' health. But for the sake of presentation, we'll discuss these separately. First, the program must reduce or mitigate the malariogenic potential. We will talk more about malariogenic potential in the next few slides, and then how to reduce it. Second, the program must ensure the early detection of cases, prompt treatment, and rapid response to try to prevent onward transmission. These activities have already been well described in the surveillance module, Unit 5, but we will review some of the specificities for the prevention of reestablishment. Third, there needs to be good collaboration across all sectors that could affect the reestablishment of malaria, including the ministries of tourism, agriculture, education, and the military. We will not cover this topic in this module because it was already well covered in Unit 8. Fourth, there must be effective cross-border collaboration, and we will touch on this topic in this module. And fifth, travelers' health is an important component of prevention of reestablishment, not only to protect travelers from the potentially severe consequences of malaria infection, but also to potentially reduce the risk of importation of malaria. In the subsequent slides, we'll cover reduction of malariogenic potential, rapid response, cross-border collaboration, and travelers' health. Underlying all of these strategies is the need to ensure that they are sustainable. As we said several times, these measures must continue until there is no more malaria in the world. Countries will need to find ways to integrate some activities into the health system to ensure that they continue to be supported financially, while other activities may need to be institutionalized in the education curriculum or made permanent through some other mechanism. In this section, we'll explain what malariogenic potential is and the strategies that can reduce or mitigate the potential for malaria transmission to be reestablished. We have discussed 6 conditions that favor reestablishment of transmission. They can be distilled down to 2 main factors that determine how much risk of reestablishment there is in a malaria-free area: the level of receptivity and the risk or rate of importation. The risk of importation used to be referred to as vulnerability, but since vulnerability is generally taken to apply to risk of harm, the more specific terms risk or rate of importation are now used. Receptivity is the degree to which an ecosystem in a given area at a given time allows for the transmission of malaria. Receptivity is largely determined by the malaria vectors in the area. An area with a large number of efficient malaria vectors will be more receptive to malaria transmission than an area with a low number of vectors. The risk or rate of importation is the likelihood that parasites will be imported into the area, either through the movement of infected people or the flight of infective mosquitoes. Malariogenic potential is the combination of these 2 factors. An area with no malaria mosquito vectors has no malariogenic potential, even if a busload of malaria-infected people move into the area. And similarly, a malaria-free area with a large population of efficient malaria vectors has no malariogenic potential if there are no parasites to be found. But put a population of hungry mosquitoes together with a busload of malaria-infected visitors, and you will have malaria transmission. Let's review each of these 2 concepts and then their combination. We covered the concept of receptivity in Unit 4 on vector control, but we'll review it again here. Receptivity is a construct developed during the Global Malaria Eradication Program that is commonly accepted to mean the degree to which an ecosystem in a given area at a given time could support local malaria transmission. Receptivity of an area to transmission of malaria is obviously related to the capacity of the vector population in the area to transmit malaria infections. If mosquito density is too low, or the vectors in the area prefer to feed on cattle, or if the daily survival rate is so low that no mosquitoes survive the extrinsic incubation period, then the capacity of vectors to transmit malaria will be very low. The types of vectors in an area and their vectorial capacity are key components of receptivity. However, note that the definition of receptivity applies to an ecosystem. An ecosystem is more than just the vectors. An ecosystem also includes humans, the parasite, and climate. So receptivity of an area is also affected by the human population, the parasite species, and the climate. Let's consider different factors and how they affect receptivity. Receptivity increases with increasing capacity of the vectors in the area to transmit malaria. The more vector mosquitoes bite humans, the higher the level of receptivity. That means that areas with high numbers of efficient vectors will be more receptive. However, the use of effective vector control can reduce receptivity by preventing mosquitoes from biting humans. Receptivity will also increase in warmer and wetter weather. Warmer temperatures speed up the development of the parasite in the mosquito and the mosquito's growth, leading to more infective mosquitoes. Wetter weather increases the availability of breeding sites for mosquitoes, which contributes to greater numbers of mosquitoes and a higher level of receptivity. Receptivity will also increase as population immunity declines with decreasing transmission. As there will be fewer people with partial immunity to malaria after elimination, they will be more likely to infect mosquitoes. That is, there is no transmission blocking immunity, and more likely to acquire infection when bitten by an infective mosquito. The level of receptivity varies geographically and over time. Receptivity is a complex concept, and there is no gold standard for measuring receptivity, but we'll talk about 3 approaches on the next slides. We have seen that receptivity is the degree to which an ecosystem allows for transmission of malaria in a specific area. But how do we measure receptivity? Because it is such a complex concept, there is no way to directly measure receptivity. However, we can get an estimation of receptivity from any of 3 different sources: entomological data, recent case data, and historical data. Let's look at each of these in turn. We know that receptivity is related to how efficient and numerous vector mosquitoes are in an area. Malariologists have developed a parameter called vectorial capacity that approximates the number of new infections arising per day from all the bites on one infectious human, with certain assumptions. We covered this concept in Unit 4 on vector control. This concept of vectorial capacity summarizes all the important features of a population of malaria vectors and their environment at a given point in time. However, as we learned in the session on entomological surveillance, it is very difficult to measure these variables in the field. Therefore, it might be possible to use a proxy measure for vectorial capacity, such as vector abundance, to estimate receptivity instead of using the full formula. Many countries measure the presence and number of vector mosquitoes as a crude indicator of receptivity. We just saw how we might estimate receptivity using data on malaria vectors in an area, but we also learned that it can be difficult to measure all of the components of vectorial capacity. So let's look at another method to estimate receptivity that uses data on malaria cases. You may already have heard about reproductive numbers, which are written as R with a 0 subscript, also referred to as R0. Reproductive numbers express the transmission potential of a newly introduced infection given certain conditions. In practice, this is calculated as the average number of secondary infections arising out of a single case. In this illustration, a traveler has imported a case of malaria. After he is bitten by local malaria vectors, 2 more people are infected. One of them transmits his infection to 3 other individuals through the bites of infective mosquitoes, while the young girl transmits infection to only 1 additional person. In the 3rd generation of infections, 1 adolescent girl infects 3 more people, 1 adult man infects no one, and a pregnant woman infects 1 man. The man infected by the young girl transmits his infection to 2 more people through the bites of infective mosquitoes. As a result, there are 12 secondary cases arising from 7 primary cases. So the reproductive number, R0, is calculated as the average number of secondary infections, or 12 divided by 7 primary infections, which equals to 1.7 in this instance. Therefore, for every index case, there will be an average of 1.7 secondary cases. This gives us a measure of the receptivity of malaria. If the R0 in an area is much greater than 1, that means that transmission will continue, and we say that the area is receptive. However, if the R0 is much less than 1, then malaria transmission would end in a short number of generations, and we say that the area is not receptive. We have discussed 2 approaches to estimating receptivity: one using entomological parameters and the other calculating R0 using information on recent cases. The third and final approach to estimating receptivity is the use of historical data on malaria prevalence or incidence as a proxy for receptivity. This is a map of the Greater Mekong subregion showing malaria incidence data in 2012. In future, after countries in this area eliminate malaria, they will be able to use this historical map as a proxy for receptivity. This approach to using historical data is appealing because it is fairly straightforward if there are data available from past surveys or malaria surveillance. However, this approach assumes that there have been no changes to receptivity in the intervening years. Malaria programs basing their estimation of receptivity on historical data will need to consider how long it has been since the historical data were measured, and whether there are any environmental or population changes that have occurred in the interim that could affect receptivity. In the end, countries will often use a combination of all three methods, entomological, case data, and historical data, as well as expert knowledge of the area to estimate receptivity. We've completed our review of the three methods to estimate receptivity. The other factor that is needed to estimate the malariogenic potential is the risk or rate of importation. Estimating the risk or rate of importation may be relatively more straightforward than estimating receptivity. The most important source of data comes from the malaria surveillance database that is recording information on all imported cases. Over the years, these data can be summarized to identify the areas of the country with the greatest number of imported malaria cases. The risk or rate of importation can be determined from an understanding of the travel patterns and population flow in an area. Often this information is local knowledge and can be determined by asking key informants, such as local officials or community members. Key informant interviews can also be combined with participatory mapping exercises, using local knowledge to identify areas where there is greater risk of entry of people from malaria-endemic areas, particularly if these populations are engaged in illegal activities or the population movement is recent. Finally, mobile phone data are becoming increasingly useful for identifying areas experiencing influxes of people from malaria-endemic areas. Although still technically challenging to implement, it is hoped that this approach can move beyond the research sphere to become more useful to malaria programs. The rate of importation can change rapidly due to natural disasters or conflict, and as a result, prevention of reestablishment programs must remain aware of current events and always consider the impact of population movement on the malariogenic potential of an area. The interaction of the two main factors that determine the risk of reestablishment, that is, receptivity and risk or rate of importation, determines the magnitude of an area's malariogenic potential. Unfortunately, there is no easy formula to calculate malariogenic potential per se. As we've said, this is a useful construct, but it is not quantifiable. The malariogenic potential should be estimated for each of the administrative units of the country or area. Juxtaposition of the two factors, as shown in this table, makes it possible to identify areas with malariogenic potential and a risk for reestablishment of transmission. If the value of one factor is 0, the possibility of malaria reestablishment is null, even if the value of the other is high. However, the risk of importation is never 0, even if it might be very low. That's why basic case management services, that is, detection, diagnosis, and treatment for malaria, must be present throughout a country. It is more likely for there to be places where receptivity is truly 0. For example, areas where malaria vectors don't exist, usually mountainous areas or highly developed urban centers. However, in areas where there is receptivity to malaria transmission and a risk or rate of importation of parasites, then there is potential for malaria transmission or malariogenic potential. The degree of malariogenic potential and therefore the risk of reestablishment will depend on how receptive the area is and the rate or risk of importation. As we have learned, the risk of reestablishment of transmission depends on the malariogenic potential, which will differ throughout an area or country. After elimination, the degree of intervention in an area will depend on the estimation of malariogenic potential. Let's see in greater detail what kind of interventions should be used in areas of varying malariogenic potential, ranging from 0 to high risk. In areas with 0 or very low malariogenic potential, passive case detection combined with good case management, namely quality-assured diagnosis and treatment, should be available to ensure that everyone can be diagnosed and treated quickly to avoid serious disease and death. In areas with low receptivity and low risk or rate of importation, the malariogenic potential is low, and early case detection by a vigilant general health service, complemented by epidemiological investigation of every suspected local case, may be sufficient, provided that rapid and appropriate curative and preventive measures are in place. In areas with higher receptivity and rate of importation, it may be necessary to supplement these activities with active case detection or targeted drug administration around an index case. In localities with high malariogenic potential, it may be necessary to reduce receptivity during the transmission season by using vector control measures. Either of the vector control measures for large-scale distribution, that is, indoor residual spraying, IRS, or insecticide-treated nets, ITNs, could be deployed and, where applicable, supplementary interventions such as larviciding could be used. An alternative or complementary approach could be to use reactive IRS around a confirmed case if the area has not been recently sprayed. So you can see that after elimination, the degree to which interventions should be continued will depend on the estimation of malariogenic potential in the area. The health jurisdictions of a country that has eliminated malaria will need to be stratified by estimated malariogenic potential, and then an appropriate intervention package should be tailored to the characteristics of each stratum. We will cover stratification in the next unit. Let's break into small groups for discussion. Please answer the question on the screen by selecting the country in each pair that is likely to have an easier time preventing reestablishment, assuming all other factors are equal. We will leave 15 minutes for debate and discussion and then reconvene in plenary for more discussion. Although it can be challenging to maintain vigilance for malaria in countries that have eliminated the parasite, early detection, diagnosis, and rapid response to malaria cases are critical to preventing reestablishment of transmission. Here we are again at the elimination surveillance cascade. However, there are a few changes to adjust the surveillance approach to prevent reestablishment. First, the detection of cases becomes more difficult in areas preventing reestablishment because malaria has become rare, and healthcare providers may not remember to detect suspected cases. Extra vigilance is required to prevent delays in diagnosis of malaria. This is one of the most important and dangerous changes that happens after elimination. Avoiding delays in diagnosis can be addressed by ensuring that malaria remains part of the in-service training modules and frequent reminders are sent to healthcare personnel, particularly in areas with high malariogenic potential, to include malaria among their differential diagnoses. The country may need to ensure that there is routine testing for malaria among travelers or migrants with fever. As we noted earlier, there might also need to be active case detection among groups at elevated risk of infection in areas with high malariogenic potential to improve the early detection of cases if there is a lack of access to malaria diagnosis and treatment in health facilities. Malaria must remain an immediately notifiable disease, and there must be a system to rapidly alert authorities to initiate the response. Cases must still be investigated to determine the likely location of infection. But after elimination, Many countries may integrate malaria into their epidemic or rapid response systems. These rapid response teams might be triggered by a confirmed malaria case or other epidemic or outbreak-prone disease, such as COVID-19, Ebola, cholera, measles, and many more. Rather than the malaria program, the rapid response system may investigate and respond to malaria cases. Reactive interventions should be implemented according to the national protocol. Reactive case detection should be undertaken to strengthen the surveillance system. Another difference from the elimination phase is that there is no immediate need to conduct a focus investigation if cases are imported. The country should have surveillance guidelines that determine the type of response based on the estimated malariogenic potential of the area and the case classification. These responses, which could include reactive case detection, reactive drug administration, or reactive IRS, can be implemented immediately according to protocol. However, if local cases are identified, a focus investigation may be needed. If focus investigations are conducted, then a response plan should be developed to address the drivers of transmission. To better understand how surveillance should be reoriented for prevention of reestablishment, let's consider a case study from Sri Lanka. Sri Lanka eliminated malaria in 2012. However, parts of Sri Lanka are considered highly receptive, and Sri Lanka's proximity to India means that there are often imported cases of Plasmodium vivax. Between 2013 and 2017, 278 imported malaria cases were identified. Here's an example of how the surveillance system has operated in Sri Lanka since elimination. On 12 December 2018, a Sri Lankan national sought care for a febrile illness that included respiratory symptoms. 14 days later, on 26 December, he was diagnosed with Plasmodium vivax malaria. He had never left Sri Lanka. On the 18th of December 2018, an Indian laborer from a construction site in Monongalala, about 160 kilometers east of Colombo, sought treatment for a bout of fever and was found to be positive for Plasmodium vivax. Both cases were notified to the Sri Lankan National Malaria Program, the anti-malaria campaign, within 24 hours, and the program responded immediately. Both cases were investigated. The Indian national was found to have an imported case of malaria, as his symptoms started about 1 month after arriving in Sri Lanka. The investigation of the Sri Lankan national found that he had spent a day and a night at the end of November at the same construction site where the Indian national worked. The parasites from both cases were genotyped and found to be identical. Although the Indian national was asymptomatic at the time the Sri Lankan national slept at the construction site, the program determined that the Sri Lankan case was introduced, being the first generation from the imported case. The response to these cases was immediate and extensive. Reactive case detection was initiated among all those with similar exposures to the two cases, and all other Indian nationals working at the construction site were provided with radical cure for Plasmodium vivax to ensure that there was no remaining reservoir of infection. Entomological investigations were undertaken in several places. ITNs were distributed, and IRS was implemented. Parasitological surveillance was strengthened, and everyone who had visited the construction site was traced to their current residence and tested for malaria. Awareness campaigns were carried out door to door. Health facilities were alerted to the potential for malaria cases, and malaria diagnostic capacity was strengthened. As a result of this rapid and thorough investigation and response, no onward transmission of malaria occurred. This is an example of how a vigilant surveillance system in a country that has eliminated malaria can respond quickly to interrupt transmission before it can become reestablished. Multi-sectoral collaboration is a key area of activity for prevention of reestablishment. Unit 8 already covered this topic in depth, so we won't repeat that here. Just note that multi-sectoral collaboration will need to continue past elimination into the prevention of reestablishment phase. Border regions are important for the prevention of reestablishment because these are often the areas with the greatest malariogenic potential after elimination. A country working to prevent reestablishment needs to have a functioning mechanism to share information and collaborate with neighboring countries on preventing malaria in border regions. Border areas often have higher malariogenic potential than interior areas because of the high rate of importation with frequent border crossings of local populations and shared vector populations. In addition, vector control in border areas may be less efficient if not also conducted on the higher transmission side. As a result, both the receptivity and rate or risk of importation may be higher along borders. Countries sharing international borders need to start cross-border collaboration as soon as possible, but is particularly urgent after elimination, as it is a key activity to prevent reestablishment. There are three main objectives to cross-border collaboration. First, there is the need to share critical information to improve the responses on both sides of the border. This information sharing includes information not only on malaria cases, but also on implementation of interventions and other factors that could affect the malaria situation, such as internally displaced persons or natural disasters. Second, both countries should commit to maximizing access to malaria interventions in areas that share populations of mosquitoes and humans. If interventions are implemented on only one side of a shared focus, then the effective coverage is significantly reduced because a portion of the population is not covered. Third, when there are outbreaks or epidemics crossing borders, all affected countries should harmonize their responses to effectively interrupt transmission and quell the outbreak as quickly as possible. Cross-border collaboration must be to the benefit of both countries, not just the country with the lower or no burden of malaria. As we'll cover in the next few slides, cross-border collaboration works best when there are shared interests and goals and minimal barriers to communication and coordination. The first step in developing cross-border collaboration is a joint analysis of the shared border regions. From a malaria perspective, there can be a great variety of conditions in border areas that affect the current or potential transmission of malaria. Unless these are identified and understood, a plan for collaboration may be incomplete. Next, the two countries need to identify and agree on their shared goals. Optimally, the shared goal will be elimination and prevention of reestablishment of malaria in shared foci. However, for many high-burden countries, their borders with countries preventing reestablishment are actually their lowest transmission areas. Finding a common goal in such a situation might be more difficult, but emphasizing the benefits of kicking off subnational elimination of malaria might convince political leaders in higher burden countries. Once the goals have been clarified, an action plan can be developed identifying the shared or coordinated activities. Coordination mechanisms are critical and may need to operate at different levels. At the national level, there may be existing regional coordination mechanisms that can be used. These may include regional program manager meetings held by WHO or other institutions. However, a local coordinating mechanism is also needed, which may take the form of regular meetings between local officials. A written agreement is important as a record of the decisions reached by those negotiating the collaboration. Formal, high-level agreements may be needed to gain approval by officials at subnational levels. Once activities have been implemented, the results need to be monitored to ensure that activities are continuing as planned and having the intended effect. We mentioned that collaboration mechanisms need to be established to ensure that sharing of information and coordination of activities occur. There are many types of mechanisms that may be needed. First, a high-level agreement may enable government officials at lower levels to participate in the cross-border collaboration. It sets out the terms and scope of the collaboration and authorizes other officials to act collaboratively. Second, meetings will need to take place between programs. It is always best to identify an existing coordination mechanism for these meetings, and regional or sub-regional meetings held by WHO or other multilateral organizations can serve as a platform for bilateral coordination. If these meetings are not sufficient, or there is an opportunity, regular bilateral meetings between countries can also serve the purpose of managing the collaboration. Specific issues related to the collaboration may need to be worked out in designated committees, and this should also be managed at a higher level. Third, some collaborations may benefit from data sharing platforms and dashboards. However, it is important that these platforms be seen as a means to an end, which is improved information exchange and monitoring, rather than an end in itself. Finally, much of the real work of the cross-border collaboration will take place at the local level. It is very important to ensure that there is at least a small amount of funding for frequent meetings at this level to enable officials along the border to get to know their counterparts and exchange information. Simple messaging apps can be used to ensure rapid and effective communication at the local level. Cross-border collaboration is one of the more difficult aspects of malaria elimination and prevention of reestablishment because the responsibility for the collaboration goes beyond any single program or single country. Nevertheless, it is of critical importance for countries to get to elimination and prevention of reestablishment. Finally, let's talk about the importance of travelers' health in programs to prevent reestablishment. Once malaria has been eliminated from an area, the immunity of individuals living in that area will begin to wane until, eventually, there is little to no population immunity to the parasite. This puts residents at increased risk of severe disease and death if they are infected while traveling in a malaria endemic country. Countries preventing reestablishment of transmission should develop a program to reduce the risk of malaria among travelers as a way to reduce their chances of severe disease and as a way to reduce the risk of importation. Many countries establish travel clinics that residents can attend to get information on the disease risks associated with their travel to different countries. WHO recommends that travelers and their advisors note the 5 principles, the ABCDEs of malaria protection. A, be aware of the risk, the incubation period, the possibility of delayed onset, and the main symptoms of malaria. B, avoid being bitten by mosquitoes, especially between dusk and dawn. Travelers can use insect repellent on exposed skin or on clothing to prevent biting. ITNs are excellent means of personal protection while sleeping. WHO also suggests mosquito coils and aerosol sprays to reduce indoor biting. Protective clothing, with or without the application of a repellent, can also help to reduce indoor biting and outdoor biting. C, take anti-malarial drugs, chemoprophylaxis, when appropriate, at regular intervals to prevent acute malaria attacks. WHO has recommendations for the most appropriate chemoprophylactic anti-malarial drug by destination. Chemoprophylaxis should be prescribed by physicians, taking into account the type of malaria risk in the areas to be visited and the contraindications of the medicine. It is very important to take the correct dosage and to adhere to the dosage regimen. While no anti-malarial prophylactic regimen gives complete protection, good chemoprophylaxis significantly reduces the risk of fatal disease. D, immediately seek diagnosis and treatment if a fever develops 1 week or more after entering an area where there is a malaria risk, and up to 3 months, or rarely even up to a year, after departure from a risk area. Even with chemoprophylaxis, there is the possibility of malaria infection, and current or recent travelers should seek diagnosis and treatment as soon as possible, being sure to mention their recent travel. E, avoid outdoor activities in environments that contain larval habitats, such as swamps or marshy areas, especially in late evenings and at night. In general, travelers should limit their outdoor exposure in areas with ongoing transmission of malaria, particularly where outdoor biting vectors predominate, to reduce their risk of infection. These recommendations are clearly beneficial to the traveler and may also help reduce the chances of importation of parasites into areas that are preventing reestablishment of transmission. To prevent reestablishment, surveillance systems must maintain a high level of vigilance for suspected cases of malaria. This is often difficult for countries that have eliminated malaria and may no longer perceive malaria as a threat. In small groups, Identify at least 3 approaches that you could adopt in your country to improve the likelihood that malaria cases will be detected by the health system after elimination. In sum, after elimination, the risk of reestablishment of malaria transmission is determined by the malariogenic potential of an area, which is a combination of the rate or risk of importation of malaria infections and the receptivity of the ecosystem to transmission. Receptivity can be estimated through entomological indicators, reproductive numbers, or historical malaria transmission indicators, whereas the rate or risk of importation can be measured directly using surveillance data or estimated through local knowledge. Vigilance for suspected malaria cases must be maintained, and surveillance systems must respond quickly to imported or introduced infections to prevent onward transmission. Awareness, avoiding bites, use of chemoprophylaxis, immediately seeking diagnosis and treatment, and avoiding outdoor environments are the ABCDEs of traveler health.